Thank you, Dr. Ibrahim, for the presentation. We have some questions that arrived. The first question will be to Dr. Qaddoumi. The question is, for low-grade glioma that is relapsing, shall we do a rebiopsy to see the change in the driving mutations before we assign a treatment for the children with the relapsed low-grade gliomas, or shall we carry on with the first mutation that have we detected in the first surgery?
I would not repeat biopsy just to look into the change in mutation. Low-grade gliomas to be based on imaging, and we didn't know the type of a mutation the patient have. And again, a lot of low-grade gliomas do not need biopsy. You can treat based on imaging, like optic pathway glioma, tictally tumors, especially when there is NF1. So if you can avoid surgery, that will be great. But to answer the question simply, no.
Thank you, Dr. Ibrahim. So another question here. So we know there is delayed diagnosis in CNS tumors. How can you avoid over use of scanning after campaigns for early diagnosis?
Yes, and you noticed, thank you, this is really good question. And you noticed my anxiety in my talk, and that's why heavy heat to avoid imaging. In my opinion, most of children with brain tumors are low-grade tumors. So unless there is signs of increased intracranial pressure, I do not see why there is urgency to do imaging. So do good history, good physical, and follow up for the patient to see if whatever diagnosis like migraine you gave to the patient improving or not. Because another danger of imaging, if you do inappropriate imaging, like the case I showed you with seizure for 11 years and the imaging comes back negative, then you even mislabel this child even worse. Another issue is you really need to communicate with the radiologist. Most of radiologists look at the brain imaging to look for bleeding, strokes, subdural hematoma, fractures, big mass like a glioblastoma. So again, thank you for this question. It's really important to avoid imaging if you can, do a targeted imaging, talk to the radiologist, and as I said, unless there are signs of increased intracranial pressure, there is no urgency in imaging.
Thank you. Yeah, and also you need to save the resources as well. Like for low-income countries, this is very important. Sedation, as you mentioned, the cost, probably all are integrated. And because also CT scans may not just answer. You may need more detailed scans like MRI.
Yes, yes. And in our countries, people pay cash from their money to ask someone like my father, Allah yarhamu, to pay $300 for MRI, a whole month's salary, and then you don't find a tumor, he will be mad at you. If you do an MRI and make them pay a whole month's salary, you better find something. It's really very important. So I'm really nervous. And another thing, we're looking at two different research projects at Global, and hopefully they will be launched soon, where we hopefully could avoid extra imaging and learn more about how we can do better job in using resources. And this is one of my, the Head Smart project is amazing, but this is one of my few concerns about it, because I think it indirectly encourages imaging because it gives red flags without the primary having someone to talk to, expert what to do and not what to do. One of our projects is that primary will have a good time to discuss with an expert in a tertiary center. This is what I have. Should I do imaging? What kind of imaging? What should I do? But thank you. This is a great question. I was hoping someone will ask that because I worry about I'm maybe causing more harm than benefit with these talks.
Thank you. Dr. Shady, do you have any other questions from your side?
Yes, for Dr. Nabil, we clinicians are asking when we should expect and what are the obstacles of having CAR T cells in the clinic for the daily management of pediatric brain tumors. What do we expect to reach the clinic? Because you know, in the leukemias and lymphomas already have reached the clinic. So what are perspective in reaching the clinic for the CAR T cells in pediatric brain tumors?
So in pediatric brain tumors, thank you for the invitation. I'm very honored. This is especially enjoyable conference. In brain tumors, the successes of CAR T cells are not as impressive as they have been in leukemias and in some lymphomas. In leukemia and lymphoma, this has been transformation of the outcome of patients, such that they have been picked by several biotechnology companies and have been approved repeatedly now by the FDA. The brain tumors has its own obstacles. The access to the tumor, the microenvironments tend to be very hostile. There are several obstacles before this would come to the clinic. I think it will be several years with an optimistic view still.
Okay, thank you very much. Dr. Nisreen, any questions?
I don't see more questions here. Oh, yes, there's one question here. It says I think this is for you, Ibrahim, in BRAF mutated low-grade gliomas, would you recommend starting with chemotherapy or anti-BRAF treatment? It's exactly the one I was thinking of. Do you see these targeted therapies or molecular targeted therapies coming to be the first time before chemotherapy, Ibrahim? We know you showed us some of the challenges associated with these medications. Besides cost, their unknowns are a lot because of the duration, because of the side effects profile and all these things. Do you see them becoming the first line of treatment?
So when someone says BRAF mutation, for me, this means the V600E.
Yes.
Not the BRAF fusion. Well, I know why Nisreen is saying this, and the person who's asking the question, because there was a study from sick kids where it showed V600E mutated tumors are less responsive to targeted therapy, because we know historically that, and from sick kids' work and others, that they are more resistant to conventional chemotherapy. But again, the cost, $12,000, maybe it's less expensive in other countries, but it's a few $1,000s per month. I think for life, it's like CML therapy and imatinib, I think. For CML, patients will be on it for 10, 12 years. So I think this is an issue for politicians and healthcare makers, healthcare policymakers, what to do with these patients, how much willing the society is to invest in treating them.
Yeah, I agree. I think there is one more question here. I think, DIPG. So diffuse intrinsic pontine gliomas. I think this is really the $1 million question. Do you see anything in the pipeline as a novel therapy? And I guess that's for both of you, Dr. Ibrahim and Dr. Nabil. Is there any promise with new medications coming up for the IPGs?
I think Dr. Nabil better to answer this one, because if there is anything novel, it will be CAR T cell. For me, the answer is no. So I will make it simple. It's for Dr.
I think it's DIPG, of course, is the most depressing tumor. That's the one we diagnose in the emergency room. Actually, there is fortunately some promise. There are trials now looking at giving CAR T cells for DIPG. Specifically, there is a trial that targets the diacylganglioside GD2 in DIPG, and it's actually opened both at Texas Children's and at Stanford University. At Stanford, we have seen preliminary data that looks actually very promising, including stabilization. The patients, of course, because of the critical position of the tumor, there is a lot of anxiety about giving CAR T cells. But Dr. Michelle Monge and Crystal Mackel have taken this very bold and brave step. And I'm very optimistic about this trial in particular.
Great. Dr. Shady, do you have more questions?
I think there is no more questions arriving to us.
Okay.
I would like to announce that for all the attendees, if you would like to have any question, to send it through the forum. It will reach the chairpersons every time. Even during the presentation, it will reach the chairperson, and the chairperson will ask the presenters after the end of the session. So if there is no more question, I would like to thank everybody. Dr. Nabil, Ahmed, thank you for the early morning session. Dear friend Ibrahim, thank you for reaching to us this morning. Dr. Nisreen, I hope to see you next year in Alexandria.
Inshallah. Thank you.
And see you next year, inshallah. Goodbye, everybody.
Goodbye. Thank you for the organization. Thanks. Thanks, everyone.